Hello there, fellow viewers. Welcome back to the ERMP and Beyond Interactive MCQ series channel, where we delve into intriguing medical cases designed to challenge and enhance your clinical knowledge. As we navigate through each scenario, I invite you to join me in uncovering the nuances of patient care, diagnosis, and treatment options. My goal is to create an engaging learning environment that not only tests your expertise but also expands it. So, tune in, participate actively, and let's embark on today's educational journey together. Remember, each discussion is a step towards becoming a more skilled and informed healthcare professional. Hit that subscribe button and let's dive right in. Happy learning! Case number 15, a 50-year-old male patient came with a complaint of sudden onset severe chest pain which radiates to the back of 4 hours duration. His blood pressure is 160 by 90 mm mercury. Cardiac biomarkers and ECG are normal. Chest X-ray shows widened mediastinum. What is the most likely diagnosis? A. Myocardial infarction. B. Aortic dissection. C. Aortic regurgitation. D. Hypertensive urgency. You have 25 seconds to answer the case. Aortic dissection, aortic regurgitation, and hypertensive urgency are distinct cardiovascular conditions that can present with overlapping symptoms but have different underlying pathologies and clinical features. Myocardial infarction typically presents in middle-aged to older adults, but can occur in younger individuals, especially with risk factors like smoking or familial hypercholesterolemia. The chest pain in myocardial infarction is often described as a crushing or pressure-like sensation or discomfort, radiating to the arm or jaw, and may be accompanied by shortness of breath, nausea, and diaphoresis. Chest pain of myocardial infarction is gradual in onset. Blood pressure may vary, but cardiac biomarkers such as troponins will be elevated, and ECG changes often include ST elevation or T wave inversions. Chest X-ray findings are usually not diagnostic but may show pulmonary edema in the case of heart failure. The clinical scenario described suggests a condition that is characterized by severe chest pain radiating to the back, normal cardiac biomarkers, and a widened mediastinum on chest X-ray. These findings are less indicative of myocardial infarction, as normal cardiac biomarkers and ECG would typically be abnormal in such cases. Aortic regurgitation can occur at any age but is more common in older adults or those with connective tissue disorders. The chest pain is less common and may be associated with exertion. Patients may present with symptoms of heart failure, such as shortness of breath and fatigue. The blood pressure condition may show a wide pulse pressure, and ECG can show left ventricular hypertrophy due to chronic volume overload. Chest X-ray findings might include an enlarged cardiac silhouette and signs of heart failure. Aortic regurgitation is not typically associated with sudden onset severe chest pain or a widened mediastinum. Hypertensive urgency is a situation where blood pressure is extremely high, often systolic above 180 mm mercury and/or diastolic above 120 mm mercury, but without acute end organ damage. Hypertensive urgency can occur at any age but is more common in adults with poorly controlled hypertension. The chest pain of hypertensive urgency can be variable and nonspecific. There are typically no elevations in cardiac biomarkers unless there is concurrent end organ damage like in hypertensive emergency. ECG and chest X-ray findings are generally nonspecific but may show signs of chronic hypertension, such as left ventricular hypertrophy. So hypertensive urgency does not explain the widened mediastinum or the acute presentation with severe chest pain of this patient. The most likely diagnosis in this scenario is aortic dissection. Let's discuss about this condition. An aortic dissection is a serious and life-threatening condition defined as a tear in the innermost layer of the aortic wall, called intima, which results in high-pressure blood flow between the layers of the aorta, creating a true and false lumen between the intima and adventitia. Aortic dissection is classified based upon the anatomic location of the entry tear, the clinical severity of the dissection, and the duration of symptoms. These all impact the options for and timing of treatment. The anatomic location and extent of the aortic dissection are determined using cardiovascular imaging. Chronologically, aortic dissections are defined as acute, subacute, or chronic. An acute aortic dissection is diagnosed when the onset of symptoms occurs within 14 days. If the diagnosis is made between 14 days to 90 days after the onset of symptoms, it is termed subacute. Beyond 90 days, the condition is considered chronic. During the first 2 weeks, life-threatening complications due to branch involvement or aortic rupture are more likely to occur. This temporal classification is crucial as it guides the management and therapeutic approach for the condition. Acute dissections often require urgent surgical intervention due to the risk of complications such as aortic rupture or organ ischemia, whereas chronic dissections may be managed with medical therapy and regular monitoring. The two main anatomic classifications used to describe aortic dissection are the DeBakey and Stanford systems. The Stanford classification divides aortic dissections into Type A and Type B based on the location of the tear. Type A dissections involve the ascending aorta and may extend to the aortic arch and beyond, while Type B dissections occur distal to the origin of the left subclavian artery and are confined to the descending aorta. The DeBakey classification further categorizes aortic dissections into Type 1, 2, and 3. Type 1 begins in the ascending aorta and extends at least to the aortic arch, Type 2 is confined to the ascending aorta, and Type 3 originates in the descending aorta, typically distal to the left subclavian artery. These classifications are crucial for determining the appropriate treatment strategy, as Type A dissections generally require surgical intervention due to the risk of complications such as coronary artery occlusion, aortic valve incompetence, or rupture into the pericardial sac leading to cardiac tamponade. In contrast, Type B dissections are often managed medically with blood pressure control. It's important to note that these classifications are based on the anatomical location of the dissection and the extent of the involvement of the aorta. Accurate classification is essential for the management and prognosis of aortic dissection, guiding the clinical decisions regarding urgent surgical repair versus conservative medical management. Ascending aortic dissections are almost twice as common as descending dissections. The right lateral wall of the ascending aorta is the most common site. Isolated abdominal aortic dissection is sporadically reported and can be due to iatrogenic, spontaneous, or traumatic mechanisms. The infrarenal abdominal aorta is more commonly involved than the suprarenal aorta. Coming to the etiologic classification, aortic dissection that has a sporadic, or degenerative, etiology is not associated with any known genetically mediated syndromes. Patients with genetically mediated syndromic thoracic aortic aneurysm include those associated with Marfan syndrome, vascular Ehlers-Danlos syndrome, Loeys-Dietz syndrome, and Turner syndrome. Non-syndromic genetically mediated disorders are most commonly familial thoracic aortic aneurysm and dissection. Traumatic aortic dissection can be related to a blunt injury mechanism or iatrogenic in nature related to instrumentation, for example such as catheterization and dissection following aortic repair. The primary conditions classified under acute aortic syndromes are the classic acute aortic dissection, intramural hematoma, and penetrating atherosclerotic ulcer. Aortic dissection is the most common and severe form, involving a tear in the inner layer of the aorta, allowing blood to flow between the layers of the aortic wall, leading to separation, dissection. It could be spontaneous or iatrogenic. In spontaneous form, Intramural bleeding causes disruption of the medial layer, which results in formation of a false lumen partitioned from true lumen by an intimal flap. In most cases the inciting event is intimal tear or an ulcer, but sometimes the rupture of vasa vasorum causes a bleed within the media. The dissection can propagate proximally or distally from intimal tear to involve the aortic root, aortic valve, coronary arteries, side branches of aortic arch and descending aorta. Aortic intramural hematoma defined as hematoma within the medial layer of the aorta, in the absence of detectable intimal tears. Aortic intramural hematoma occurs when a rupture of the vasa vasorum leads to bleeding within the aortic wall layers without an intimal tear. Recent studies show that microscopic tears in the intima is the possible mechanism of bleeding into the medial layer of the aorta. Therefore, there's no imaging evidence of intimal flap or false lumen within the aorta. Presence of blood within the medial layer provokes an inflammatory response. This weakens the components of the aortic wall, and consequently it may lead to aortic rupture. Penetrating aortic ulcer refers to the region of the aorta where the aortic intima is denuded with the lesion progressing through a variable depth of the aortic wall, over which there may or may not be overlying thrombus. Penetrating aortic ulcers are typically associated with atherosclerotic changes of the adjacent aortic wall. It may be associated with thrombus formation within the media, or may progress through the adventitia to form pseudoaneurysm, and finally perforation or aortic dissection may happen. Periaortic hematoma represents a contained aortic rupture due to slow oozing from the damaged aorta at or near the site of aortic injury. The distinguishing features of these conditions are primarily identified through imaging techniques such as CT, MRI, or transesophageal echocardiography. For instance, aortic dissection may present on imaging as a false lumen with an intimal flap, while intramural hematoma is identified by a crescentic or circular thickening of the aortic wall without an observable intimal tear. Penetrating aortic ulcer will appear as a contrast-filled-out pouching or ulceration within the aortic wall. Clinically, acute aortic syndromes often presents with sudden, severe chest or back pain, which can mimic myocardial infarction, making clinical assessment challenging. Other symptoms may include syncope, stroke, or limb ischemia, depending on the extent and location of the aortic involvement. Blood pressure discrepancies between limbs and a new diastolic murmur indicative of aortic regurgitation may also be observed. As we will see in few minutes, management strategies for acute aortic syndromes vary based on the specific diagnosis and the severity of the condition. Type A aortic dissection typically require urgent surgical intervention, whereas Type B aortic dissections may be managed medically or with endovascular techniques in certain cases. The management of intramural hematomas and penetrating aortic ulcer are often similar to that of the classic aortic dissections, the approach being influenced by the lesion size, location, and by clinical stability of the patient. The primary pathophysiologic event in the classic aortic dissection is a tear in the aortic intima. Degeneration of the aortic media, or cystic medial necrosis, is felt to be a prerequisite for the development of non-traumatic aortic dissection. Blood passes into the aortic media through the tear, separating the intima from the surrounding media and/or adventitia and creating a false lumen. It is uncertain whether the initiating event is a primary rupture of the intima with secondary dissection of the media or hemorrhage within the media and subsequent rupture of the overlying intima. 50 to 65% of aortic intimal tears originate in the ascending aorta within the sinotubular junction and extend to involve remaining portions of the thoraco-abdominal aorta. Approximately 20 to 30% of intimal tears will originate in the vicinity of the left subclavian artery and extend into the descending thoracic and thoraco-abdominal aorta. The commonality of these two predominant locales for development of the aortic tear is hypothesized to be related to shear forces being highest in these regions. The dissection can propagate proximally or distally to involve the aortic valve and enter the pericardial space or branch vessels. Such propagation is responsible for many of the ischemic clinical manifestations, including aortic regurgitation, cardiac tamponade, or ischemia, myocardial ischemia, cerebral ischemia, spinal ischemia, or visceral ischemia. Patients with involvement of the ascending aorta have imminent risk for aortic rupture. The intimal tear with type B dissection can spiral into a cleavage plane within the media of the aorta along the posterolateral descending thoracic aorta, leaving the celiac artery, superior mesenteric artery, and right renal artery, typically originating in the true lumen, with the left renal artery deriving false lumen flow. Variations in anatomy of the dissection are typical and underscore the critical need for proper axial imaging. In addition, multiple communications may form between the true lumen and the false lumen. Immediately following dissection, there is intrinsic true lumen collapse to a variable degree, and false lumen dilation, thus increasing the aortic cross-sectional area. The increase of the false lumen area correlates with blood pressure, the size of the entry tear into the false lumen, the depth of the dissection plane within the media, and the percentage of aortic circumference involved. Because the outer wall of the false lumen is thinned, it expands to generate the necessary wall tension to accommodate aortic pressure. The true lumen collapses as a result of the pressure differential between the true and false lumens and may be exacerbated by the intrinsic recoil of the muscular elements within the dissection flap. The mortality of acute aortic syndromes is a consequence of its complications. Aortic dissection as the prototype of this syndromes can give rise to a variety of organ dysfunction either by rupture or by malperfusion of organs. Malperfusion of aortic branch vessels may occur due to the extension of the dissection throughout the thoraco-abdominal aorta. Malperfusion of a vascular bed can occur in one or more branch territories simultaneously. Malperfusion syndromes may occur in 30 to 45% of descending dissections and correlate with early mortality. The malperfusion may be dynamic, static, or mixed. Dynamic malperfusion is the most common and results from the overpressurized false lumen pushing the septum toward the true lumen, leading to collapse of the true lumen and obstruction of branch vessels. Static malperfusion results from stenosis or occlusion of a branch artery caused by the dissection flap, hematoma, embolism, or thrombosis. The diagnostic criteria for malperfusion syndromes involve a combination of clinical presentation, imaging findings, and laboratory values. Clinically, patients may present with symptoms indicative of organ ischemia, such as neurological deficits, abdominal pain, or limb ischemia, depending on the affected vascular territory. Imaging techniques, such as CT angiography, MRI, or transesophageal echocardiography, are employed to identify signs of compromised blood flow to organs or limbs. These may show evidence of true and false lumens, as well as the involvement of branch vessels. Laboratory tests can reveal elevated lactate levels or other markers of organ dysfunction, which support the diagnosis of malperfusion. This table summarizes the high-risk conditions commonly associated with aortic dissection. The most important predisposing factor of acute aortic dissection is systemic hypertension. In the IRAD review, 72% of the patients had a history of hypertension. Hypertension was more common in those with a type B dissection compared with a type A dissection. More importantly, an abrupt, transient, severe increase in blood pressure has been associated with acute aortic dissection through various mechanisms. Crack cocaine, which may cause transient hypertension due to catecholamine release, accounted for 37% of dissections in a report of an inner-city population. The mean duration from last cocaine use to the onset of symptoms was 12 hours. High-intensity weightlifting or other strenuous resistance training can also cause a transient elevation in blood pressure and has been reported as an antecedent. Hypertension is also the postulated mechanism when energy drinks or ergotism have been associated with aortic dissection. The incidence of aortic dissection is higher in older patients than in younger patients. In young patients, aortic dissection is typically associated with connective tissue disorders, such as Marfan syndrome, Ehlers-Danlos syndrome, and Loeys-Dietz syndrome. In the so-called IRAD review, Marfan syndrome was present in 50% of those under age 40, compared with only 2% of older patients. Most patients with Marfan syndrome and aortic dissection have a family history of dissection. There may also be an association between Marfan syndrome and aortic aneurysm in the third trimester of pregnancy. In the review, 13% of pregnant patients had a known aortic aneurysm prior to dissection. The ascending aorta was more often the site of origin of the dissection than the aortic arch or descending aorta. Such a history was more common in patients under age 40. The other high-risk conditions associated with acute aortic dissection are recent aortic surgery, aortic coarctation, bicuspid valve, Turner syndrome, underlying atherosclerosis, and vasculitic disorders. The clinical pictures of aortic dissection are caused by various mechanisms. The first mechanism is dynamic obstruction of the true lumen by the false lumen. The second mechanism is extension of the false lumen to a vessel that branches off the aorta. Due to the large number of vessels that can be affected, the clinical presentation varies widely, which makes it challenging to diagnose the condition. Rates of misdiagnosis for aortic dissection range from 14 to 38%. Although acute aortic dissection can occur at any time of the day, the onset of symptoms more commonly occurs in the morning during waking hours. Pain is the most common presenting symptom, is occurring in over 90% of patients, with 85% of the patients note that the onset to be abrupt. Typically the pain is severe and sharp knife-like, causing the patient to seek medical attention within minutes to hours of onset, and categorically unlike any pain experienced before. Pain can occur in isolation or be associated with syncope, a cerebrovascular accident, acute coronary syndrome, heart failure, or other clinical symptoms or signs. Generally, there are 14 potential pain sites associated with aortic dissection. Chest pain is the most common symptom, followed by back pain. If there is upper limb ischemia as a result of the dissection event, then arm pain may occur. While the pain is typically described as anterior chest in location in type A dissection, for type B dissection, the pain is more often experienced in the back. The classic ripping or tearing character of pain is described only in 50% of patients. The pain is more often described as sharp, in 68%, and less often as migratory, in 19%. Older adult patients, who are above 70 years, are less likely to have an abrupt onset of pain compared with younger patients. Physical findings are highly variable and range from virtually unremarkable to full cardiac arrest secondary to tamponade or rupture. The findings may signify complications related to dissection. The presence of these findings must raise clinical suspicion for aortic dissection, but their absence does not exclude dissection and should not deter pursuit of the diagnosis when suspected. The presence of hypotension complicating a type B dissection is rare. It is seen in less than 5% of patients, and usually implies aortic wall rupture. By contrast, hypotension may be present in 25% of dissections that involve the ascending aorta. Hypotension in type A dissection should prompt you to consider occurrence of complications such as acute aortic valve insufficiency, which occurs in up to 10% of cases, cardiac tamponade, hemothorax, hemoperitoneum, acute coronary syndrome, which is responsible for 1 to 2% of cases, or it could be due to pseudohypotension. Acute coronary syndrome more commonly involves right coronary artery, though left-sided STEMI is not uncommon. Virtually any patient with STEMI is not safe from aortic dissection-induced myocardial infarction. Aortic dissection may not be suspected as a cause of coronary ischemia, and misdiagnosis may lead to inappropriate therapy and delays in treatment. Hypertension is present in 70% of type B dissections, but it occurs in only 25 to 35% of type A dissections. The underlying pathophysiology of hypertension could be attributed to either hyperadrenergic response to pain or renal arterial occlusion, renal ischemia. A pulse deficit occurs when there is a discrepancy between the heartbeats and the palpable pulses, such as when the heart contracts but not all beats result in a perceivable pulse. This can be measured by comparing the apical pulse, typically auscultated at the heart's apex, with a peripheral pulse like the radial pulse at the wrist. The difference between these two rates is the pulse deficit, and it implies impaired or absent blood flow to peripheral vessels. The impaired or absent blood flow may result from the intimal flap or compression by hematoma. A considerable variation, of more than 20 mm Hg, in systolic blood pressure may be seen when comparing the blood pressure in the two arms. BP differential of more than 20 mmHg between arms is historically reported as a significant clinical predictor. However, studies have demonstrated that 50% of patients without aortic dissection also will have a BP differential of more than 10 mmHg between arms, and 19% have a BP differential of more than 20 mmHg. Therefore, BP differential is less useful than a palpable pulse deficit. In International Registry of Acute Aortic Dissection reviews, women are less likely to have a pulse deficit than men. Compared with younger patients, older adult patients, those over 70 years, were significantly less likely to have any pulse deficit. With respect to isolated lower extremity pulse deficits, mortality from lower extremity ischemia or its sequelae is uncommon. Nonetheless, leg ischemia caused by acute dissection is a marker of extensive dissection and may be accompanied by other compromised vascular territories. The clinical course of the peripheral ischemia can be quite variable, and up to 1/3 of this group may demonstrate spontaneous resolution of their pulse deficits. Patients with a pulse deficit have a higher rate of in-hospital complications and mortality compared with those without a pulse deficit. Therefore, a rapid bedside pulse examination can provide important information in the diagnosis of acute aortic dissection and those at risk for complications. Aortic dissection that propagates proximal to the initial tear can involve the aortic valve. A new diastolic murmur in association with severe acute chest pain is a sign of acute aortic regurgitation. Characteristically, it is a diastolic decrescendo murmur associated with a wide pulse pressure, hypotension, and/or heart failure. Acute aortic valve regurgitation occurs in 1/2 to 2/3 of ascending dissections. The murmur of aortic regurgitation related to aortic dissection is most commonly heard along the right sternal border, as compared with the left sternal border for aortic regurgitation due to primary aortic valve disease. The duration of the diastolic murmur may be quite short due to rapid ventricular filling and early equilibration of aortic and left ventricular diastolic pressures. Stroke or altered consciousness can be from direct extension of the dissection into the carotid arteries or diminished carotid blood flow. Alterations of consciousness are more common in women than in men. Horner's syndrome results from compression of the superior cervical sympathetic ganglion. Hoarseness also can be caused from vocal cord paralysis due to compression of the left recurrent laryngeal nerve. Finally, acute paraplegia may result from spinal cord ischemia. Spinal cord ischemia from the interruption of intercostal vessels is clearly more common with type B aortic dissections than with type A dissections, and it may occur in 2 to 3% of all patients. Coma and cerebral malperfusion are associated with poor outcomes. Aortic dissection that does not involve coronary ostia can usually be distinguished from acute coronary syndrome by the nature and location of the chest pain and the absence of ECG changes characteristic of ischemia. However, the ECG is less helpful when dissection leads to coronary ischemia. In many cases, the ECG may appear normal or show nonspecific ST segment and T-wave changes. These nonspecific changes can make the diagnosis challenging, as they may overlap with findings seen in other cardiac emergencies such as acute coronary syndromes or pulmonary embolism. However, certain ECG patterns can raise suspicion for aortic dissection, particularly if they are accompanied by severe sharp or tearing type pain or features of other malperfusion syndromes. For instance, if aortic dissection leads to an interruption of blood flow to the right coronary artery, as in the case of a Stanford type A dissection, one might observe ST segment elevation in the inferior leads. Biomarkers and risk stratification tools have been studied to rule out aortic dissection. The American Heart Association developed the Aortic Dissection Detection Risk Score, which is the only decision rule to date that has been validated. The Aortic Dissection Detection Risk Score is a clinical tool designed to estimate the likelihood of aortic dissection in a patient presenting with symptoms suggestive of this condition. The Aortic Dissection Detection Risk Score is based on a set of 12 clinical markers that are evaluated in patients when aortic dissection is considered in the differential diagnosis. These markers include factors such as the patient's history, physical examination findings, and certain clinical features of the pain experienced by the patient. The score categorizes patients into 3 risk levels: low risk, if the score is 0 points, intermediate risk, if the score is 1 point, and high risk, with score of 2 to 3 points. Patients with a score of 0 are considered at low risk for aortic dissection and may not require immediate imaging, while those with a score of 1 are at intermediate risk and should have expedited imaging if no other immediate cause of symptoms is identified. Patients with a score of 2 or 3 are at high risk and are recommended to proceed directly to imaging to confirm or rule out aortic dissection. In patients admitted to the hospital with chest pain and suspicion of aortic dissection, these laboratory tests are required for differential diagnosis or detection of complications. Liver and renal function tests are required specially in descending aortic dissection to rule out end-organ ischemic injury. In contrast to traditional belief holding that elevated serum lactate is a marker of organ hypoperfusion, anaerobic metabolism, several studies, in patients with septic shock, show that this is not true. Elevated serum lactate represents endogenous catecholamine release, stimulating beta-2 receptors. This stimulation upregulates glycolysis, generating more pyruvate than can be used by mitochondria by tricarboxylic acid cycle. Excess pyruvate is converted into lactate. Toxicology screening may be considered in young patients without apparent clinical risk factor for stimulant drugs abuse. The results of toxicology screening may alter the pharmacological agents chosen for acute medical management. D-dimer is a degradation product of cross-linked fibrin and reflects activation of the extrinsic pathway of the coagulation cascade by tissue factor exposed in the aortic media by the intimal tear. As such, D-dimer has emerged as a potential serum marker for acute dissection. However, as a nonspecific indicator of intravascular coagulation, D-dimer can be elevated in many conditions. D-dimer appears to be a useful screening tool to identify patients who do not have acute aortic dissection. A widely used cutoff is 500 nanogram per milliliter. A level below this value is highly predictive for excluding dissection. The measurement of D-dimer levels in the blood can be used to further stratify risk. A negative D-dimer result, typically defined as less than 500 nanogram per milliliter, in conjunction with an aortic dissection detection risk score of 0 or 1, has been shown to have a high negative predictive value for acute aortic dissection. This combination of aortic dissection detection risk score and D-dimer testing can help reduce the number of unnecessary imaging studies performed, which is particularly important given the potential risks associated with exposure to radiation and contrast agents. The diagnosis of acute aortic dissection may be suspected clinically based upon the presence of high-risk clinical features, but confirmation of the diagnosis requires cardiovascular imaging that demonstrates the dissection flap separating a false lumen from the true lumen. A high index of suspicion is important for identifying patients with acute aortic dissection to avoid a missed or delayed diagnosis. It is important to rapidly distinguish acute ascending thoracic aortic dissection, which is a cardiac surgical emergency, from acute descending thoracic aortic dissection, which is managed medically in hemodynamically stable patients who do not have malperfusion or other complications. In general, definitive vascular imaging studies should not be performed until the patient can be initially stabilized. The imaging diagnosis of aortic dissection is based on the presence of an intimal flap separating a false lumen from a true lumen. Imaging also can help visualize associated complications. In most cases, the true lumen may be localized by its continuity with an undissected proximal or distal segment of the aorta. The presence of intraluminal thrombus is a good marker of the false lumen, but in patients with a concomitant degenerative aneurysm, thrombus may be present in the true lumen. In the majority of cases, the false lumen is larger than the true lumen. A compressed true lumen is the key radiographic finding, which should substantially raise the index of suspicion for malperfusion syndrome. Curving of the dissection flap into the true lumen is seen in 63% of acute type B dissections but only 25% of chronic dissections. Plain chest films are commonly obtained to help rapidly differentiate the various causes of chest pain, such as pneumothorax. The most common abnormality seen in aortic dissection is widening of the aortic silhouette, appearing in 60 to 90% of cases. Radiographic evidence of a pleural effusion can be found in 19% of dissections. This finding is more common in women than in men. Other findings, which are less specific for dissection, are widening of the aortic contour, displaced calcification, aortic kinking, and opacification of the aorticopulmonary window. Hemothorax may be seen if the dissection extends through the adventitia, with hemorrhage into the pleural space, which can lead to exsanguination. The calcium sign is a finding on a chest X-ray that suggests aortic dissection. It is the separation of the intimal calcification from the outer aortic soft tissue border by 10 mm. This is not an important sign for radiographers given that it is rarely seen. However, because of the limited sensitivity of the chest radiograph, especially in type B dissections, additional imaging studies are obtained in almost all patients. For hemodynamically unstable patients or those with clinical features suggestive of ascending aortic involvement, transesophageal echocardiography is suggested as an initial study in patients with suspected aortic dissection, wherever available. Transesophageal echocardiography is a portable procedure that yields a diagnosis within minutes and is easily performed in the emergency department. The sensitivity of transesophageal echocardiography has been reported to be as high as 98%, and the specificity ranges from 63 to 96%. The ascending aorta is typically assessed at approximately 130-degree orientation, while the arch and descending thoracic aorta are assessed at 0 degrees. Also, biplane imaging may be useful. Wide availability, ease of use, and bedside capability are some of the advantages of transesophageal echocardiography. In addition, transesophageal echocardiography can detect entry-tier sites, false lumen flows, thrombus, involvement of the arch or coronary arteries, degrees of aortic valvular regurgitation, and pericardial effusions. The addition of color flow Doppler patterns may decrease false positives by recognizing differential flow velocities in the true and false lumens that may assist in the diagnosis of malperfusion syndromes. A disadvantage of transesophageal echocardiography is that it requires esophageal intubation, which usually requires procedural sedation, which may have untoward effects in hemodynamically unstable patients. The other disadvantage is that transesophageal echocardiography requires the availability of experienced operators to ensure accurate results. As such, it is often not attainable on a stat basis in many centers. The theoretical technical limitation of transesophageal echocardiography is the anatomic blind spot in the distal ascending aorta and proximal arch secondary to the air-filled trachea and left main stem bronchus, and inability to document dissection extension beyond the diaphragm that may be causing malperfusion of abdominal aorta branches. A less favorable alternative to transesophageal echocardiography is transthoracic echocardiography, which can sometimes identify proximal ascending aortic dissection with the assistance of color flow Doppler and echo contrast, but is particularly valuable for identifying complications associated with dissection. The primary disadvantage with transthoracic echocardiography is its inability to adequately and fully visualize the mid and distal ascending, transverse arch and descending aorta, or the presence of other complications in a substantial number of patients. Furthermore, the sensitivity and specificity of transthoracic echocardiography are inferior to CT angiography and transesophageal echocardiography. For hemodynamically stable patients without clinical features suggesting ascending aortic involvement, CT angiography as an initial study of choice in patients with suspected aortic dissection, particularly in the emergency department setting where other studies are less available. In comparison with other modalities, CT scanning is the least operator-dependent, provides useful anatomic correlates for surgical and endovascular therapy, and collects information for follow-up analysis and measurement. Most importantly, three-dimensional CT scan reconstructions can aid treatment planning, and axial imaging affords the best opportunity to detect topographic relationships of the true and false lumens and potential aortic branch compromise. CT scanning has a reported sensitivity of 83 to 95% and specificity of 87 to 100% for the diagnosis of acute aortic dissection. The chief limitation of imaging is the ascending aorta, where the sensitivity may drop to less than 80%, as contrast enhancement can be dependent on timing of the injection. The accuracy of CT may be substantially improved with spiral or helical CT and perhaps with multi-detector or multi-slice CT. Spiral CT may be more accurate than MR or transesophageal echocardiogram for the detection of aortic arch vessel involvement. A potential limitation is a spiral CT artifact that can simulate an aortic dissection flap in patients if performed without echocardiogram gating. Thus, ECG-gated scanning is recommended when available. Diagnosis of aortic dissection by CT scanning requires the identification of two distinct lumens since the intimal flap may or may not be demonstrated. Advantages of CT are ready availability at most hospitals, even on an emergency basis, and identification of intraluminal thrombus and pericardial effusion. Two disadvantages of standard CT are that the intimal flap is seen in less than 75% of cases and that the site of entry is rarely identified. In addition, potentially nephrotoxic iodinated contrast is required, and there is no capability to assess for aortic insufficiency. The general principles of the treatment of acute aortic syndromes are similar to acute aortic dissection. A crucial aspect of early therapy is ensuring an early and correct diagnosis so that the appropriate treatment can be instituted in a timely fashion. Approximately 2/3 of aortic dissections present as type A, and 1/3 are type B. Patients with suspected acute aortic syndromes should be admitted to an intensive care unit as rapidly as possible after confirmation of the diagnosis for pain control with morphine and anti-impulse therapy to reduce systolic blood pressure, which is often elevated, typically using beta blockers. A toxicology screen should be considered in any patient presenting with an acute aortic syndrome, particularly if there are no other known predisposing factors. The results of toxicology screening may alter the pharmacological agents chosen for acute medical management. Patients generally require blood pressure monitoring with an arterial line to facilitate rapid management of changes in blood pressure. Patients who are hemodynamically unstable or with airway compromise should be intubated. Acute medical therapies should not interfere with timely transfer to the operating room for those in whom immediate surgery is indicated. Before fluid volume is administered, hypotensive patients should be evaluated to determine if the cause is hemopericardium with tamponade, valvular dysfunction, or left ventricular systolic dysfunction. In patients with cardiac tamponade, percutaneous pericardiocentesis can accelerate bleeding and shock. Acute medical management of acute aortic dissection involves controlling pain and providing anti-impulse therapy in the form of blood pressure lowering and decreasing the velocity of left ventricular contraction, to decrease aortic shear stress and minimize the tendency for the dissection to propagate. Medical treatment of acute aortic dissection should not interfere with the timely transfer to the operating room for those patients with indications for immediate aortic repair. Aortic dissection involving the ascending aorta is a cardiac surgical emergency since these patients are at very high risk for early life-threatening complications such as acute aortic regurgitation, cardiac tamponade, and myocardial infarction. Transesophageal echocardiography should be routinely performed in the operating room to assess aortic valve function, evidence of tamponade, and aortic root and ascending aortic diameter. The aortic root and ascending aorta move about 15 mm per cardiac cycle. Anti-impulse therapy aims to reduce the velocity of left ventricular contraction, thereby decreasing pulse pressure-related shear stress and minimizing lesion progression. However, it should not be administered when hypotension, aortic insufficiency, and/or concern for cardiac tamponade is present because this intervention may blunt the patient's compensatory tachycardia, leading to cardiovascular collapse. Administration of anti-impulse therapy should not interfere with the timely transfer of the patient. Anti-impulse therapy is usually accomplished with antihypertensive therapy, typically using intravenous beta blockers. Inotropic agents should be avoided since they will increase aortic wall shear stress and may lead to progression. Systolic blood pressure should be reduced to the lowest level that is tolerated while maintaining end-organ perfusion. Therefore, regular mentation or urine output measures are helpful to follow to ensure adequate end-organ perfusion. Initial treatment consists typically of an intravenous beta blocker to reduce the heart rate to 60 to 80 beats per minute. Esmolol is useful in the acute setting due to its short half-life and ability to titrate to effect. Esmolol is also advantageous in patients who might be intolerant of beta blockers due to asthma or heart failure. For example, labetalol can be given as a bolus or as an infusion. Diltiazem or verapamil are alternatives in patients who cannot tolerate beta blockers. If after beta blockade the systolic blood pressure remains elevated, nitroprusside can be added, if needed, to achieve a systolic blood pressure of 100 to 120 mm mercury. Nitroprusside should not be used without first controlling heart rate with beta blockade since vasodilation alone induces reflex activation of the sympathetic nervous system, leading to enhanced ventricular contraction and increased aortic wall shear stress. Patients receiving nitroprusside should be continuously monitored, preferably using an intraarterial cannula from the arm with the highest auscultatory pressure. While nitroprusside is the preferred second-line agent, intravenous nicardipine, clofidipine, ACE inhibitors, verapamil, or diltiazem may also be effective in lowering blood pressure. Other direct vasodilators, such as hydralazine, should be avoided since they increase aortic wall shear stress and provide less accurate and reversible control of the blood pressure. Means to provide pain control other than antihypertensive therapies are warranted. This may include intravenous opioids as needed or patient-controlled analgesia as would be administered to a postoperative patient, in the absence of contraindications. Pain refractory to optimal medical management has been associated with worse outcomes in patients with aortic dissection. However, recurrence of pain may not always be associated with failure of medical therapy. Cocaine toxicity results from central monoamine reuptake inhibition and its sodium channel blockade properties. Initial management in patients with acute cocaine toxicity should aim to reverse centrally mediated sympathetic nervous system stimulation. Beta blockers are generally avoided in patients with acute cocaine intoxication as they may lead to unopposed alpha stimulation and worsening the situation, but selective beta blockers such as esmolol or mixed agents such as labetalol may be reasonable for treating patients with acute aortic dissection or other acute aortic syndromes, when needed. Calcium channel blockers or nitroglycerin can be used in conjunction with esmolol or labetalol if additional blood pressure lowering is needed. For patients with acute aortic dissection, anti-impulse therapy is usually initiated prior to learning the result of any drug screening, and as such, many patients do receive beta blockers. Surgical intervention for acute aortic syndromes depends upon the location of the involved aorta, symptoms, and the presence of complications. In general, type A lesions are treated with urgent surgical repair, whereas in many cases type B lesions can be treated with ongoing medical care. Type A aortic dissection is a surgical emergency. Rupture of the dissected aorta is fortunately uncommon but is an ominous complication with certain mortality unless prompt surgical intervention can be undertaken. The development of malperfusion in type A aortic dissection is associated with mortality rates up to 44%. Similarly, treatment of type A aortic intramural hematoma is aggressive to prevent progression to aortic dissection or rupture. Among medically treated patients, mortality rates range from 33 to 40%. It has also been suggested that good outcomes can be achieved in type A intramural hematomas when therapy is guided by specific patient characteristics and only those deemed at high risk for complications are taken for surgery. However, progression can also occur in patients with smaller diameter lesions. The treatment of type A penetrating aortic ulcer is also emergency surgery owing to its natural history and predilection for rupture. Even asymptomatic acute ascending or arch-penetrating aortic ulcers should generally be managed operatively as these do not appear to follow a benign course. The risk of rupture of a type A penetrating aortic ulcer may be as high as 33 to 40%. Graft replacement of the ascending aorta is the standard treatment of a penetrating aortic ulcer of the ascending aorta. Transverse arch penetrating aortic ulcers can be managed by open graft replacement or by using endovascular techniques, often with brachiocephalic vessel debranching. Most lesions associated with acute aortic syndromes affecting the descending aorta are initially treated by medical management. Intervention, surgical or endovascular, is generally reserved for patients who have persistent severe hypertension, persistent or recurrent pain, progression to dissection or propagation of dissection, aneurysmal expansion, malperfusion leading to end organ ischemia, or rupture. An exception may be penetrating aortic ulcer associated with intramural hematoma, for which earlier intervention may be needed to prevent complications. The mortality associated with such complications can exceed 60%. The rapid evolution of the use of endovascular treatments mandates their immediate availability in the acute phase or the transfer of the patient to a regional medical center with experience and such resources. Aortic intramural hematoma is more common in the descending aorta compared with aortic dissection. Many patients with type B aortic intramural hematoma respond well to medical therapy with resolution of the aortic abnormality over time. I hope we have gained helpful clinical pictures regarding the aortic syndromes, specifically acute aortic dissection. You can also recommend on any medical topic that you want to be filmed in the future. Thank you very much for watching. Please like, share and subscribe to the channel. That is very helpful to encourage me and the channel. See you in the next topic.